Hi, everyone. We're just going to give it another few moments while we wait for folks to filter in. Thanks for being with us today. All right, well, happy Friday, everyone, and thank you for being here today. I'd like to welcome you all to our Opioid Response monthly webinar series. I'm Madison Barassa. I'm the SUD Program Manager here at the Office of Behavioral Health, working closely with Gordon Smith on the opioid response work. We have an exciting discussion for you all today. Just a few housekeeping items before we jump in. Please use the question and answer box for any questions that you might have throughout today's webinar instead of the chat feature. We will be monitoring that Q&A box, and we'll leave some time at the end of today's webinar to answer as many questions as we can. If we're not able to answer all of those questions, then we will post that to the AdCare website. Our next opioid response monthly webinar series will be held on Friday, April 7th at 11:30. We hope to announce that topic very soon, so just be on the lookout from an email from AdCare. I'm excited to introduce and welcome back Director of the Office of Behavioral Health, Sarah Squirrell, who will be moderating today's webinar. So I'll pass that over to you, Director Squirrell.
Great. Thank you, Madison. Good morning, everyone. Wonderful to have you all here today. This is the Maine Governor's Office Opioid Response webinar series. And also want to thank Madison for your support and our partners at AdCare for helping to facilitate today's webinar. We are absolutely delighted to be joined here today by Tom Coderre, the Acting Deputy Assistant Secretary for Mental Health and Substance Use. And this is such a timely conversation. There is such a sense of urgency around our opioid response work here in Maine. And we are really excited to see some of the potentially game-changing provisions through the Consolidated Appropriations Act that was passed by Congress and signed into law by President Biden, which removed many, many barriers to medication for opioid use disorder. I also just want to take a moment and highlight some of the incredible work that we have been doing here in Maine, including investments to really expand our substance use and opioid response capacity across the state. In addition to the FY 24-25 budget initiatives that the governor is proposing, in her recent State of the Budget address, she also announced several new initiatives that will be implemented immediately to support our efforts here in Maine. That includes an additional $2 million to support our capital and catalyst funds for providers to expand substance use residential treatment across the state, increasing our naloxone distribution by 25% in the upcoming year, and really excited to announce that we will be doubling the size of our options program across the state as well, which is embedding behavioral health clinicians in every county across the state in Maine. Also wanting to acknowledge that we could not do this work here in Maine if it were not for our partnership with our federal partners and SAMHSA, which is why we are so grateful to have Tom joining us here today. We're also grateful to have Tom in such a key leadership role at the federal level. He has decades of experience, both public, private, nonprofit, and is really an inspiration to us all as the first person in recovery to lead SAMHSA. And he's been a great mentor and friend to Maine, has really inspired our efforts here, particularly as it relates to our commitment and recognition of the essential role of recovery and recovery services. So thank you, Tom. And with that, I'm going to turn it over to Tom for a presentation. Thank you for being here.
Thank you so much, Director Squirrell. I was delighted to be able to work with you when you're in Vermont, and I'm so excited that you're in Maine now, helping to lead the efforts there. I'd also like to thank my dear friend and your Director of Opioid Response, Gordon Smith, for inviting me to participate in this webinar today, and to all of you who are joining us and are engaged and active in this work on a daily basis. Sarah, the announcements that you made from Governor Mills are so exciting, and really I can't thank her enough. Executive leadership matters, in this space. And when we have governors who step up to the plate, like Governor Mills has, I was so impressed by her state of the state, where she spent a lot of time talking about mental health and substance use and how this is a priority for her and her administration. So it's just so wonderful to be able to join you here today and to be able to participate in a lot of the work that you guys are doing. And I haven't been with you since the opioid summit last summer, so it's good to be back. But unfortunately, our country continues to face these unprecedented mental health and substance use crises among people of all ages and backgrounds. You guys don't need me to tell you, overdose deaths have reached another historic high, devastating individuals, families, and communities. We lost more than 107,000 Americans last year due to an overdose, and over 46 million people meet the diagnostic criteria for substance use disorder in this country. So we've got our work cut out for us. It's, illicitly manufactured fentanyl is still driving a majority of the deaths, but mortality rates due to cocaine and psychostimulants such as methamphetamine have also increased, both with and without the presence of fentanyl. So I'm glad to be here today to talk about some of the solutions that we have to this. And I have a few slides that I'd love to share with you. So if Lorna can pull up the slides for us, that would be great. And the first one, I guess we're going to run the slideshow. Second. Great. So you're in presentation mode. I see you in presentation mode. I'm not sure if everybody on the screen does as well, but you may want to change it to slideshow mode. That's perfect. And next slide. So as Sarah mentioned, the Consolidated Appropriations Act passed on December 20, well, it passed in December and was signed by President Biden into law on December 29th. So what I'm here today to do is to talk a little bit about what the federal government's doing. In the latest example of this is that federal budget omnibus, which is called the FY23 Consolidated Appropriations Act. I want to briefly share what's in the CAA, spotlight one of the significant provisions, and then share what some of the resources are that are going to be coming to Maine. Next slide. This is a little spotlight about what SAMHSA's FY23 appropriations looked like in the CAA. We received historic investments in our agency and in the programs that help people all around our country. Our mental health funding got an increase of 25%. Our prevention funding went up 8%. Our treatment funding 5%, and our surveillance resources went up 12%. Our total budget saw almost $1 billion increase in the CAA, which is a 13% increase. And if you look at the little chart that one of the congressional offices put out, that second purple bullet, the second purple balloon rather, is where SAMHSA falls in terms of who got the most money in HHS from the Consolidated Appropriations Act. So this is really a priority for Congress, all by the way of saying. Next slide. The CAA is a combination of both appropriations of federal resources and authorizations. So many of SAMHSA's programs were reauthorized, and we even received new authorizations as well. And so you'll see all of the programs that were part of the Restoring Mental Health and Wellbeing Act in here. The first bullet are all the preventing overdose programs, state opioid response, grants to prevent prescription drug opioid overdose related deaths, building communities of recovery and our recovery community services program. We had OTPs and regulatory activities in there, emergency department, alternatives to opioids program, our technology transfer centers, the comprehensive opioid recovery grants, MAT and MATE, which I'm going to talk about in a minute, targeted capacity expansion, and the family and drug treatment court programs all received additional authorizations this year. Now let's talk a little bit about MAT and MATE on the next slide. MAT is referring to the Mainstreaming Addiction Treatment Act, and MATE is referring to the Medication Access and Training Expansion Act. I want to briefly provide some background on the X-Waiver, which was really what Matt dealt with, and highlight some of the critical dates of recent SAMHSA initiatives, specifically as it relates to the removal of the X-Waiver requirement. The X-Waiver was established as part of the 2000 Drug and Alcohol Treatment Act. The Drug Addiction Treatment Act. The legislation was authorized so practitioners could use buprenorphine to treat patients in clinics rather than only in opioid treatment programs. To have the X-Waiver appended to their drug enforcement licenses, practitioners were required to complete specialized training and submit a letter of intent to the DEA and SAMHSA. Once approved, practitioners were limited in how many patients they could treat with buprenorphine. And this waiver, coined the X-Waiver after the additional DEA number that begins with the letter X, is given to providers who obtain the waiver. It initially allowed physicians to prescribe buprenorphine for up to 30 patients at a time. And after their first year, eligible providers were able to treat up to 100, and then followed by 275 patients thereafter in 2016. To further increase patient access to medications, the X-Waiver restrictions were eased in 2021, including changes that allowed other qualifying practitioners, including certified registered nurse and anesthetists, to have access to the X-Waiver and prescribe buprenorphine. Next slide. So this is really historic what happened on December 29th. The CAA amended the Controlled Substances Act to eliminate that requirement for the first time ever. And so you no longer have to obtain a special waiver to prescribe medications such as buprenorphine for the treatment of opioid use disorder. Separately, the Appropriations Act also introduced new training requirements for all prescribers. And this mandates that new DEA applicants or those with a DEA renewal to take 8 hours of training as a one-time education. So the existing X-Waiver, if you had it, would fulfill that criteria. So MAT and MATE really ride together. MAT eliminated the requirement for a waiver, but MATE is requiring not just people who prescribe buprenorphine, but anyone with a DEA registration license to get some kind of education about substance use disorder. It's huge. It's historic. We're so pleased to see that Congress took action on this. Next slide. So in support of this policy reform, on January 12th, SAMHSA and the DEA issued guidance on the removal of the X-Waiver, effective immediately. Prescriptions for buprenorphine now only require a standard DEA registration number. The X-Waiver is no longer required for any prescriber to treat patients with buprenorphine. With the new law, the patient limits associated with the special waiver also no longer apply, and SAMHSA no longer accepts waiver applications. So this new law means that we must now take active steps to ensure that elimination of the X-Waiver will significantly expand access to medications for opioid use disorder and the broader engagement in treatment services that are going to lead to better outcomes. So our goal is simple. We want medication for opioid use disorder to be readily available and safely available to anyone in the country who needs it. And the elimination of the X-Waiver is going to increase access for those in need. Next slide. Now on MATE implementation, it's a little trickier. All physicians and other healthcare professionals, as I mentioned earlier, with that regular DEA license can prescribe buprenorphine. However, these new requirements for MATE don't go into effect until June 21st, 2023. So SAMHSA is actively working with our partners over at DEA to provide further guidance, and we're in the process of developing frequently asked questions documents. Regarding the MATE requirements specifically, DEA is going to follow up with additional information in the near future to all those that are impacted by it. SAMHSA is committed to addressing the overdose epidemic through the provision of person-centered and evidence-based care. With the elimination of the special waiver, SAMHSA strongly encourages all practitioners as permissible under state law, because we know that there's some states that have laws that govern the waiver as well, to screen each patient for opioid use disorder and offer access to medications. At SAMHSA, we also understand the value of working with other federal, state, and local partners and leveraging these partnerships to support a coordinated approach to addressing the needs of people in need of improved access to prevention, treatment, and recovery-oriented systems of care. Next slide. Now let's just look a little bit about Maine. Two of our biggest programs are block grant and SOAR grant. So I have two slides here to just talk a little bit about those. The Substance Abuse Prevention and Treatment Block Grant, as it used to be known, has now been changed to the Substance Use Prevention, Treatment, and Recovery Services Block Grant. So we removed the stigmatizing language of abuse in the name of the block grant, and then really expanded it out to the full continuum that we know states use to fund programs. SAMHSA's Center for Substance Abuse Treatment, in collaboration with the Center for Substance Abuse Prevention, administered that block grant, and Maine is going to receive a bump in their block grant dollars by almost $400,000 to continue to do the important work that you're doing. You went from 7.1 million to 7.5 million in the block grant. Next slide. And then on state opioid response grants, another flagship program of ours, which is commonly referred to just as SOAR. It's similar to the block grant. This program awards states and territories through the single state agencies dollars to address the opioid crisis by increasing access to medication-assisted treatment, reducing unmet treatment needs, and reducing opioid overdose. And then in 2020, this program was expanded to include stimulant misuse. So Maine is nationally recognized for your model of providing critical services such as medications for opioid use disorder, behavioral health therapy, and programs in your jails and prisons, which I've had the opportunity to visit and have been really, really impressed with. So Maine is receiving a little bump in their SOAR resources as well, going from $6.3 million annually to $6.5 million as a result of the Consolidated Appropriations Act. In addition to SOAR, there's also TOR grants for tribal entities, and we've really enjoyed working with our friends at Wabanaki Public Health on all the work that they're doing to address these issues in tribal communities. Next slide. I think this is my last slide, and then we're going to have a discussion. I really want to congratulate you on your continued dedication and the strides you've made to saving lives and expanding services here in Maine. Thank you also for your work in spreading the hope of recovery. As a person in recovery, as Sarah mentioned, for me, that's critically important. I also want to thank our regional team, my assistant regional director, Taylor Brian Turner, our acting regional director, while I'm on detail to SAMHSA headquarters, Jeff Cody, and our public health fellow, Tamika McCants, who have been so supportive of all of you folks in Maine. I know if you guys ever need anything, please reach out to that team. They will be there for it. And remember, SAMHSA is your partner in this fight. We're working across government to offer programs, services, training, strategies, and other supports to respond to the behavioral health needs of Americans. And we really appreciate the partnership that we have with Sarah and Gordon and everybody else on the team there. So with that, I'll turn it back over to you, Sarah.
Great. Thank you, Tom. That was a great overview, greatly appreciated. Certainly the reauthorization of these critical funding sources are absolutely essential to our work here in Maine. Not to mention removing that stigmatizing language that has languished for some time. So that's also very exciting. And I think these efforts at the federal level to increase our funding here in Maine, paired with the investments that we're making here, will just continue to advance our work. One data point I think that we can be quite proud of here in Maine is that since we began our work to distribute naloxone, we have, through January of 2023, distributed over 280,000 doses of naloxone here in Maine. So just hats off to the efforts at the community level to support that work.
That's amazing.
Yeah, and I think we also recognize here in Maine just how important medication is. It's really the gold standard, and there's no one size fits all. So our goals are always to ensure that access to medication for treatment is expanded, is easy. I also wanted to highlight a couple other data points that are somewhat hot off the press that our audience might be interested in. In the second half of 2022, nearly 1,000 more Mainers received buprenorphine prescriptions. And during that same time period, Mainers enrolled in methadone increased by 350 individuals per month. So that's an 8% increase, which is tremendous. And just also want to thank our prescribers who are likely in the audience here today, because you are really on the front lines of this work and we couldn't do it without you. And Tom, one of the other areas I'm really interested to get your perspective on, in addition to the Consolidated Appropriations Act, my understanding is that there's some proposed rulemaking under 42 CFR that could impact our opioid treatment programs, medication, and perhaps care coordination as well. Could you talk a little bit about that?
Sure. We are in the middle of rulemaking, so I'm limited in what I can share about it, but we have issued a notice of proposed rulemaking and accepted comments on several rules earlier last year on 42 CFR Part 2, which deals with patient confidentiality. So thank you to everyone who provided comments to us as we work to, based on the SUPPORT Act, align 42 CFR more with Part 2 with HIPAA. A lot of folks have been interested in this in Congress and across the country, and we think that the rule strikes that balance, but we are reviewing those comments and we'll continue. We'll be back with a final rule in the coming months, and then we can give you a little bit more information about that one. On 42 CFR Part 8, this is really has to do with modernizing some of the rules about medications for opioid use disorder. The flexibilities that were provided during the COVID-19 PHE, they've been met with widespread support among patients, the OTPs, and state authorities. And we've seen studies that have demonstrated that the flexibility didn't lead to any more deaths involving methadone. The sky did not fall, as as some of our SSAs have said. And so SAMHSA's proposed changes that support clinical judgment and person-centered care. Clinical judgment includes consideration of the risks as well as the benefits of providing take-home methadone doses, even starting at the beginning of treatment. So we have made some specific changes. The rule revises admission criteria, removing the 1-year threshold during the duration of addiction required for OTP admission. The proposed rule defines services to be provided in medication units. It makes permanent the flexibilities of the use of telehealth to initiate medications for opioid use disorder. There's overall Part 8, really the updates are to reflect evidence-based practice, treatment standards, and the workforce currently providing services in OTPs. So we are very, very excited about this rule. It also, in the rule, removes some of the stigmatizing language that was in the previous language, like taking the terms drug abuse and detoxification and legitimate treatment use out of that federal regulation. So thank you for anyone who's submitted comments. Those comments closed already. We have a supplemental rule because of the Consolidated Appropriations Act. We had to issue a supplemental rule that closes on March 14th. So if you have any interest in commenting on that, please submit your comments and we'll be back in touch with you about that.
Great. Thank you, Tom. And we have already benefited here in Maine of seeing increases in our OTP providers across the state. As I mentioned, increases in medication and increases in our main care claims for services, which is also a great sign and indication, and also underscores the significance of our expansion of those services here in Maine as well. One other area I wanted to ask you about, and some of our audience might be interested in, and something we've been thinking a lot about here at the Department of Health and Human Services is really managing the end of the PHE, the public health emergency, some of the unwinding and how it might impact some of the flexibilities that we really leaned into during the pandemic, which quite frankly really helped advance our work as it relates to behavioral health care. One in particular was the Ryan Hyatt Act, and during the public health emergency, the DEA suspended some of those requirements, which allowed telemedicine to be used a bit more broadly as it relates to prescribing medication. I understand that the DEA is proposing rules to permanently allow those telemedicine flexibilities. And I think in Maine, this is so important because of our rural population. And this expansion really allowed more access in those rural areas where we might have limited regional geographic access. So just wondering if you had anything to add to that or anything else related to the unwinding of the public health emergency.
Well, part of our rulemaking on Part 8 was in recognition that the public health emergency for COVID would eventually end. And we wanted to make sure that providers and patients alike knew that we were committed to the changes that were made and the flexibilities that were allowed during the COVID pandemic that were successful, that we were committed to continuing those. So you did see that in our Part 8 rulemaking. The Ryan Haight Act rule, the DEA telemedicine registry regulation is not our rule, it's DEA's rule, but you're absolutely right, that did post about a week or two ago, and that is in anticipation also of the COVID PHE ending in a few months. And so the summary of that rule is that patients really have to be in the presence of a DEA registered provider at a DEA registered facility, or have had an eligible referral by a DEA registered provider, or have an in-person evaluation within 30 days of the telemedicine that was provided to them. It could be audio only if the patient's not able to or refuses an audio visual encounter, and the name and the NPI, the registration number, are required to be documented. The evaluation has to include a PDMP check. The prescription must contain a language that it was a telemedicine visit. There's some fees associated with this special license that providers would have to obtain. And then there's some documentation requirements as well in the rule. But the bottom line is that there's going to be a mechanism to continue telehealth for buprenorphine and other controlled substances. It's going to require the special registration, but there will be guardrails in place to minimize the risks, whether it be diversion or other risks. And if you have comments, that rule is only open for 30 days, I believe. So I think it closes on March 31st, but we encourage you to go and check out in the Federal Register where these rules are posted, and issue any comments that you might have for the DEA to consider as they complete their rulemaking process.
Great. Thank you, Tom. That's incredibly helpful and also encouraging as well. I guess
yeah, I mean, that I do. Can I just jump on that for a second? Because it is incredible and it is really exciting, because we're seeing as we move forward here, as COVID was this unfortunate experiment. It allowed us to do some things that we weren't able to do otherwise, that there wasn't either public policy support for or public support for in the past. We got to try out some stuff and to do an experiment and pilots of these different policies where, we have for a long time, advocates have really petitioned the government to reduce some of these barriers that patients have had. And so this is pretty groundbreaking, this rulemaking to make these things permanent. And I think it's going to really have a huge impact on the ability for people to get care.
Yeah, I couldn't agree more. It feels like we're at such a transformational point that's just going to give us the tailwind that we need to keep doing this work.
That is the hope.
And I guess on that note, certainly here in Maine, every life lost to opioids, we feel so deeply. We feel this urgency to act, to continue to have stamina. But it also sometimes feels like we're running a marathon to some extent, and they keep moving the finish line on us. And we know how important hope is. Hope is what drives us to heal. It's the belief that things can get better. And I'm wondering if you have any words of wisdom for us here in Maine. How do we maintain that hope and stamina as we continue to combat the opioid crisis here in Maine?
Oh my God, Sarah, that's an incredibly important question, an incredibly difficult one to answer, because I wake up every day, and I know you do as well, and all the folks at SAMHSA do, wondering about this, about whether what we're doing on a day-to-day basis is making a difference, whether we're having the impact that we want to have. And what I can say to you is that we are, that I saw the 2022 numbers from Maine, and what, obviously was saddened by the fact that they increased, because I know that every one of those lives lost was somebody's mother or father, sister or brother, friend or partner, some kind of loved one. And that hurts. And that's really incredibly painful to go through. But what was encouraging to me was to see that over 90% of the overdoses in Maine resulted in a life saved. That really points to the fact that what you're doing is working. The naloxone distribution, fentanyl test strip distribution, the recovery coaches that are engaging on a day-to-day basis with people who use drugs, other harm reduction strategies that you're doing are working, getting people engaged, whether it be in a process to go across the stages of change and become ready to go to treatment, or whether it be to actually get somebody into a withdrawal management program or a treatment program. So incredibly important, or just into a recovery community center, which have expanded tremendously in Maine. So as a person in recovery, I live on that hope that you talked about. I live every day on that hope, and I have a lot of promise for the future. And while this work can be incredibly frustrating at times, because it does feel like the finish line is moving, as you so aptly put it, but we are making a huge difference, and we got to double down our efforts. That's why you're seeing Congress continue to invest resources. President Biden is talking about this in his State of the State, putting people in recovery in his cabinet. We're continuing to this rulemaking, which is continuing to advance our field in a really important way. I think we're going to have more and more impact as we go, but we can't give up. We have to continue to every day get up and ask what more we can do.
Well, thank you, Tom. I think that's exactly what we all needed to hear. And I think it also, makes me think about some of the strengths that we have here in Maine, which is just our collective commitment, our ability to work together. This is not just a DHHS issue. This is a community issue. And I feel like in Maine, all of our partners have come together: Department of Public Safety, EMS, frontline responders, law enforcement, our community partners, our recovery partners. And I think sometimes we think our best way to serve the system is to optimize our part in it. And I think what we've done here in Maine is really optimize the relationships between the parts to get the outcomes that we're after as it relates to our opioid response. So again, just want to thank everyone on the call today who is assisting us in those efforts. And we are truly all in this together. So with that said, I want to make sure, I'm sure there's lots of folks that have questions. So I'm wondering if maybe we'll pause now and we'll take Q&A questions. And I think Madison's going to assist us a little bit with that.
Yeah, thank you. So we do have a couple of clarifying questions. One that came in is, does the X-Waiver fulfill the 8-hour education requirement for licensing?
Yes, you did hear that correctly, David. It does fulfill that 8-hour requirement.
Thank you. The next clarifying question is, can you just say a little more about registering as a telehealth provider?
So that is, again, part of the DEA process and will be part of that special registry, NPRM. So I don't have any specific information about that at the moment, but I'm happy to get that to Sarah so we can get that out to folks when it's available.
Wonderful. Some of the statistics that were shared on buprenorphine prescriptions, and they're just asking if that's PMP data and if that includes cash purchases at the retail pharmacy.
Oh, that's a great question. It is PMP data, and I would have to get back to folks as it relates to the pharmacy question.
Wonderful, thank you. There were a few clarifying questions just in regards to the amount of naloxone that was purchased and distributed within the state of Maine. So I don't know, Director Squirrell, if you could just restate how many doses and what that time frame was.
Yes, I believe, Madison, it's been over the past 3 to 4 years, and it was 238,000 doses as of January of 2023.
And I think the person who put the question in was saying that it's actually more than that because there are people that don't even have to report that. So that's what you can count. But we know that there's additional doses that probably were administered as well by people who are not a reporter.
Yeah, that's a great point. Thank you. Another question that came in regards to naloxone within Maine is a question if there will be any expansion of nalox boxes at community locations around the state.
Yeah, another great question. That is something that Gordon and I talk about a lot. So it's something that we're currently looking into. We may need some legislative support statutorily to accomplish that. So I would say stay tuned, but certainly something that Gordon Smith and I talk about quite a bit.
Wonderful, thank you. I know there were a couple of questions in the Q&A just in regards to some of the information that was shared on the block grant, specifically what the change was in the amount that Maine receives through that block grant.
I think specifically for the substance use block grant, I believe our increase was about $377,000, just that's off the top of my head. And I know there was some desire to have a set aside for recovery as it relates to the block grant. I don't think that made it across the finish line officially. However, what I can say is that Maine will be prioritizing some of the increase in our block grant to support the expansion of recovery services, which we are really excited about.
Yeah, I can talk a little bit about that as well. You have a good memory because you're on target already. It was about 400,000 was the increase. So you probably even had a better number than I had. I just rounded to the next 100,000. But with regard to the recovery set aside, it did not, unfortunately, make it over the finish line. However, the several things did make it over the finish line, which are really important for the recovery community to take note of. One is the name change that I highlighted, which added recovery services to the block grant name for the first time ever. So that's an important change, and it signals to states that block grant should be used for recovery services as well as for treatment and prevention and other types of activities that states use those resources for. In addition to that, SAMHSA was given direction by Congress and the president to strongly encourage states to use their block grant money for recovery support services. So in our most recent application, block grant application, which was out for comment recently, we included that language in the block grant. We have also, in the Consolidated Appropriations Act, states are now required to report and disaggregate information about recovery support services. So we'll actually have an accounting of what states are spending on recovery support services for the first time ever. And it'll be disaggregated by service type. So we'll know if it went to a recovery community center, recovery coaching, or if it was an aftercare program at a treatment center, and we'll be able to see where the gaps are relative to that. So these are all super important changes that support recovery and things that I've been advocating for. I'm not supposed to advocate as a federal government official, but I've been educating folks about and trying to put forward public policy proposals around because I believe, and we at SAMHSA, as you know, established a recovery office last year, and we're really looking at making recovery and recovery oriented systems of care a huge cross-cutting principle in all of our work. For me, it's really important that we look at the end goal of somebody who's experienced substance use disorder. And for me, that end goal was recovery. And I think a lot of folks share that end goal. So when we create a system of care, we should be thinking about that as the end goal. And every piece of that system that we put together should be considering that as a patient's end goal as they're going through that system of care. And how do you support that person, in a meaningful way as they try to reduce harms of drug use, as they engage in whether it be peer support activities, treatment, prevention type activities, and how do you help them achieve well-being and ultimately thrive as an individual? Because that's what I'd like to see for folks.
Great. And my team has been monitoring this conversation and had some follow-up information as it relates to the good question on the buprenorphine and the PMP data. It does include cash purchases. So thank you to my team.
We do have another question for Tom. Jennifer Van Duzen says, hi, Tom. So good to have you here again. Just asking if there is any specific guidance for medical schools.
There wasn't any specific guidance in the CAA for medical schools, but Jennifer has been a partner on the COPE initiative and in really helping to integrate substance use disorder treatment curriculum in medical schools. That's going to continue to be a priority for SAMHSA, Jennifer, and we appreciate all the efforts that you've had around the region in helping getting this important work done. The further upstream we can go in educating practitioners, and I think some of this the MAID Act language that we talked about is going to probably help, and we can certainly talk to you, Jennifer, about how we can coordinate on that moving forward.
Wonderful, thank you. I'm just monitoring the questions that are remaining. Let's see if there are any others. In regards to providers and such as there was a specific example given, they're asking how can we get funding to pay for the $65 fee for the people trying to attend meetings but don't have insurance. Not sure if that's a question we can answer offline.
Yeah, Madison, we might need to follow up on that one.
Okay, that's good. We can do that.
And there are a couple other questions I'm just noticing, Madison. One is related to recovery-friendly workplaces, which is an area we've been very excited to advance here in Maine, and really excited that there will be a funding opportunity coming out soon, which is funded through our Opioid Prevention and Treatment Fund that will support advancing recovery-friendly workplaces across the state. So more to come. But we should see that funding opportunity be published soon.
Wonderful, thank you. What's a question in the Q&A just in regards to Black Balloon Day on Monday, March 6th. I don't know if we want to touch on that a bit.
Yeah, what a great question. Thank you. Black Balloon Day is an opportunity for us as communities to really have awareness around overdose prevention, to honor those that we have lost. So the Options social media campaign will be sharing some information and awareness about how you could participate virtually. There will probably be things occurring at the community level as well, but we will certainly be pushing out information for folks in terms of how you can participate in that awareness day. And thank you for the question.
Wonderful, thank you. I'm not sure if there was any other questions in there, Sarah, that you had flagged.
Just taking a quick peek. Some good questions as it relates to EMS applying for federal grants. Our EMS partners are so closely aligned with our work, but I can't speak to what they're currently looking at in terms of federal grant applications, but certainly I think we share your concern as it relates to outreach to the homeless population in particular. We have several initiatives to really increase engagement, including a peer navigator pilot that's going to support and complement some of our options work. That would be a priority population for us from an outreach standpoint. So again, really wanting to expand our efforts as it relates to the homeless population.
Wonderful, thank you. There is a question just in regards to access to naloxone within pharmacies, and if there is a plan within the state to address some of those barriers there. I don't know if we want to answer that.
Yeah, again, another great question, but certainly something that we are thinking about as a state. We want access to naloxone to be as easy as possible. So again, I think that's something that Gordon and I, in consultation with the administration, will continue to look at. And Tom, I don't know if there's anything else you would add to that.
I would love to. I know folks have probably seen that the FDA received an application to make naloxone available over the counter without a prescription. So a non-prescription formulation of naloxone, which could be exciting. We have to work out all the details around it, because obviously there'd be reimbursement issues, and if it's over the counter, it wouldn't be reimbursed through someone's insurance. It would be self-pay. So there's those details to be worked out, but I think you'll be seeing an announcement soon from the FDA about the status of that application and what that could mean for us going forward for an over-the-counter formulation. I think the application was for a 4 milligram nasal formulation to be available, non-prescription. So that is in our near future, I believe.
Thank you. There is a question just in regards to any consideration of providing fentanyl test strips to folks who are purchasing sterile supplies from pharmacies.
It's a great question. I know we've really worked to incorporate fentanyl test strips in terms of our distribution. I don't know, Madison, if there's anything you wanted to add as it relates to that relationship with pharmacies or anything that we've been thinking about.
I don't think I have anything to add on that. Thank you.
Okay.
But I think fentanyl test strips are an underutilized tool. Mm-hmm. And let me tell you why. I think that while we know the drug supply is predominantly fentanyl now. Fentanyl test strips still, and this is what we're hearing from folks on the ground in harm reduction programs. You know, many of you know that SAMHSA released our first harm reduction grant last year. And so in addition to that, we established a technical assistance center with the CDC to help community providers. And what we're hearing from folks on the ground is that fentanyl test strips are an incredibly important tool, engagement tool, to have a conversation with members of the general public, especially as it relates to not necessarily opioids, but as it relates to stimulants. There's so many folks who are using stimulants and overdosing because they weren't aware of the presence of fentanyl in that drug supply. So people are, you know, recovery coaches, harm reduction specialists, community members, prevention coalitions are going out into the community with fentanyl test strips and using them as an engagement opportunity to have that education conversation. So we at SAMHSA support, we changed our policies to allow fentanyl test strips to be an allowable expense in all of our grant programs because we recognize that while they may not be being used for the by some parts of the community for obvious reasons, that they still give you an opportunity to have a really important conversation with folks and can be that aha moment for somebody who might be using other types of substances that aren't aware that they could be poisoned with fentanyl. And you could potentially save somebody's life through that education.
Wonderful. Thank you so much. There was just a clarifying question in regards to the recovery friendly workplaces RFP, just in regards to when that would be launching and maybe how folks can be notified when that is.
Yeah, great question. I think I would say in the next month or two, that opportunity for funding will be made public. That will be posted on the appropriate DHHS websites, but certainly you can outreach to our Office of Behavioral Health to ensure that you can get connected and understand exactly when that funding resource is going to come available. And one other question I saw in the chat, Madison, was related to just some of the data and statistics that we shared in this presentation. Obviously, Tom's presentation captures a lot of the federal information that he shared, but we are happy to follow up and share some of those statistics with participants.
If there's anything in my presentation that folks want, I'm happy to provide any of the statistics that weren't on slides. I also saw a question in the chat about resources for rural areas. I think this is a really important question. We have a focus at SAMHSA on rural areas and a few programs that have to do with rural areas, but really our sister agency, HRSA, has done a lot in this space as well. They have that mandate, and there are several programs that are available through HRSA grants and through health centers that can help folks in rural areas. I know the question was specific to transportation and other types of resources that folks need in rural areas. So maybe Sarah, you have other information about those particular resources, but definitely there is a focus on rural.
Yeah, thank you, Tom. And I think that is one of our priorities here in Maine, and particularly as it relates to access to residential treatment programs, as well as medically supervised withdrawal programs. We have regions of the state where that access is very challenging. So one of the priorities, I mentioned the second tranche of funds for capital and catalyst funds for SUD residential treatment, is that those will be prioritized in geographic regions of the state where we are very limited in access or there is not access. So that will be one of those priorities as we move forward. We're also working on the Maine Drug Data Hub, which I would just also share with folks is a great place to go to get some information and dig into these statistics. I think Madison could probably put a link to that in the chat. We're also working on having more interactive maps as it relates to where capacity is, because the moment an individual is ready to access services or treatment is the moment you want to be able to connect them immediately. So we're trying to make sure that the public, providers, individuals who are trying to help folks can really see where that access is in more of a real-time basis. So we're working on also updating the Maine Drug Data Hub to have all of our residential programs listed clearly. And then also the Department of Health and Human Services is preparing to launch Treatment Connection, which will be another resource by which the public providers can go in and quickly see where resources are available across the state and capacity as well. And that will be launching in the next few months. All right, well, I think we are just about at time. It's amazing how quickly an hour can go by with Tom Coderre. But this has been an incredible conversation. I want to thank everyone for participating and joining us today. And Tom, just a sincere thank you to you for your time, for your leadership. We certainly could not do it here in Maine without the support of our federal partners. So just want to thank you for being here today.
Well, you know, like in any partnership, it really requires both partners to come to the table and, you know, communicate and invest in the relationship. And Maine has certainly done that with SAMHSA, and SAMHSA is trying to do its part with Maine. So thank you, Sarah, to yourself and to Gordon, to Madison, to everybody in the department and throughout state government and, you know, our local providers of prevention, treatment, and recovery support services, our harm reduction folks who are coming to the table and being part of the solution. As you mentioned, law enforcement, the courts, jails, prisons, everybody. It takes everybody to really help us get you know, turn the tide on this devastating epidemic and continue to save lives. So thank you to everybody who's doing their part to do that.
Right. Thank you, Tom. And
I wanted to recognize one other thing, and
of course,
that there's some things that we can do within government, and there's some things that we can't. And so to the folks that are out there advocating for things that government can't do, I encourage you to take it into your own hands and get the community involved and get the community engaged in some of these activities. And then when we can do it in government, we will, just like what I talked about with the rulemaking. It's taken years and years and years for us to get to that point, and lots of folks who have done stuff leading up to that to help prove concept, to do pilot programs, and to get us in a place where government then can make the decision to act. So please, I encourage you to not give up, to keep working hard at the local level to get these things done.
Great. Well, thank you, Tom. And with that, I will wrap us up for today. Thank you, Madison, for your support, and to our partners at AdCare as well. And we look forward to seeing you all at our next webinar. Thanks, everyone.
Bye, everybody.
Thank you.
Thank you.